What's up, guys? Today we are going to be doing ophthalmology tailored to the emergency medicine shelf exam. Cranial nerve 3 palsy is often acquired due to trauma, tumor, aneurysm, diabetes, but it also can be congenital. It presents with ptosis, mydriasis, and often you'll see the eye as down and out. A new cranial nerve 3 palsy with pupillary involvement needs an MRA and a CTA to rule out aneurysm. The pupil is involved when the fibers that supply the pupillary constrictors are affected. So cranial nerve 3 palsy with pupillary involvement is an aneurysm. Cranial nerve 3 palsy without pupillary involvement, or when the pupil is spared, is often due to diabetes or hypertension. Contrast this with Horner syndrome with the classic symptoms of ptosis, meiosis, and hydrosis. You want to get a CT head and a CTA for new Horner syndrome to rule out carotid artery dissection. Blepharitis is chronic staph infection of the eyelid margins. The treatment is baby shampoo and topical antibiotics. Eyelid lacerations near the medial canthus indicate lacrimal duct injury if the fluorescein staining is coming out of the laceration. Inflammation of the nasolacrimal sac caused by nasolacrimal duct obstruction is called dacryocystitis. The treatment is warm compresses and oral antibiotics. Pterygium is the triangular growth of connective tissue that starts medially and extends laterally onto the cornea. It results from exposure to sunlight and wind. There's no treatment necessary. Chalazion is chronic inflammation due to meibomian glands that are obstructed, and they're non-tender. The treatment, you don't really need to use antibiotics, but you may need surgical removal down the line. And then a stye, also known as hordeolum, is an acute inflammation of eyelid that is tender. The treatment is topical antibiotics. And for the record, just to preface, there's a lot of other hard words to pronounce for ophthalmology, so if I butcher them, I'm sorry, but I'm doing the best I can, and we'll just keep going. This is arguably the most high yield part of the video in terms of the ophthalmology section of emergency medicine shelf exam. I got a couple tables up here. Let's go over the conjunctivitis. We have viral, which is mostly due to adenovirus. It produces a watery discharge, classically starts in one eye, goes to the next eye. There's pre-auricular lymphadenopathy is common. The treatment is warm compress. Bacterial origin, you'll see purulent discharge, and the treatment is a short duration of antibiotics. And then allergic conjunctivitis is thin watery discharge that affects both eyes from the onset. The patient will describe itchy eyes, rhinorrhea, other allergy symptoms, in addition to those related to the eye. And the treatment is nafazoline. And then switching over to neonatal conjunctivitis, the first 24 to 48 hours of postpartum, those are chemical in nature. The treatment is self-limiting. 3 to 5 days is gonococcal. You treat with IV ceftriaxone and topical erythromycin. And then 5 to 14 days later postpartum, you'll see chlamydia, which is a treatment oral and topical erythromycin. Episcleritis is characterized by sudden onset, eye pain, redness. It only involves the superficial episclera vessels, so the treatment is self-limited. Scleritis, on the other hand, is rare, and it's an emergency cause of red eye. So most cases are associated with an underlying autoimmune disease. The patient will have severe pain, blurry vision, photophobia, purple discoloration of the globe. The treatment is oral steroids, NSAIDs, and ophthalmology consult. Subconjunctival hemorrhage is due to sneezing, coughing, straining, any sort of trauma. You want to check the blood pressure and evaluate for a bleeding disorder. You want to refer if the pain develops. Otherwise, there's no treatment. Anterior uveitis, also known as iritis, causes include infectious, post-traumatic, autoimmune. The patient will present with severe eye pain, tearing, and both direct and consensual photophobia. The slit lamp will show cells, which are white blood cells, and flare, or a foggy appearance of protein which has leaked from blood vessels. The pupil can be misshapen on examination. The treatment is topical psychoplegics and topical steroids. Ophthalmology should always be consulted for these patients, and you should always consult ophthalmology whenever you're trying to give topical steroids in the emergency room. Cycloplegics cause loss of accommodation and include atropine, scopolamine, those are the big two. Most often used for hyphema and traumatic iritis. Corneal abrasions are from tearing, and the patient will have a foreign body sensation, photophobia, injection. You do not place protective shields over the eye, as this can worsen infection. The only indications to ever place a shield over the eye is hyphema and global rupture. Hypopium is pus in the anterior chamber, which is accumulation of layered white blood cells seen in the anterior uveitis and corneal ulcers. Corneal ulcers are a serious corneal infection associated with trauma or prolonged contact lens wear. The patient has pain, photophobia, excessive tears, foreign body sensation. The exam will be a corneal defect with surrounding white hazy infiltrates, and this is a true ocular emergency and can lead to blindness if not treated promptly. You want to consult optho, and the patient needs an eye culture and should be started on topical quinolone drops. Ophthalmitis is a bacterial or fungal infection within the eye. The most common form occurs 6 weeks post-cataract surgery, and the presentation includes a hazy retina. The most common bacteria is coagulase negative staph, and this is an emergent consult to optho. Antibiotics are directly injected into the eye. All right, last couple of things we need to hit for optho for the ER shelf are chemical burns. You want to irrigate the eye quickly. The acidic burns are not usually associated with deep penetration because acid, remember, causes that coagulative necrosis, which you compare that to the alkali burns, which causes liquefactive necrosis. Ultraviolet keratitis is known as snow blindness. You'll see it in skiers, snowboarders, welders, tanning, people who go to tanning beds. On exam, the patient will have diffuse bilateral punctate keratitis. The treatment is analgesics, topical antibiotics. Cycloplegics will help photophobia, but should be avoided as they can cause pupillary dilation lasting for days, which can be painful to the patient in itself, right? And then lastly, I want to just compare and contrast HSV keratitis and herpes zoster ophthalmicus, which is HZO. HSV keratitis, the cornea is involved, you see this dendritic pattern branching, and there's nothing present on the skin. You treat with IV acyclovir. And then herpes zoster ophthalmicus is HZO. You'll see keratitis and ophthalmic branch of the cranial nerve 5 is involved, so there will be a rash that's present on the patient's skin. And you treat both of these with IV antivirals. And that's it. I'm sorry if I botched some of the words, but you get the general idea. You should see a couple of these on your exam. I hope this review was helpful, and please reach out in the comments if you have a better way to pronounce something or you have any thoughts. Thank you all for your time.